In this video, I will be reviewing a study of a telephone-based peer support service for people with spinal cord injury. This has come about because our clinic manager wants to explore introducing this type of intervention for young people with SCI who attend our clinic. But we need high-quality evidence supporting this idea before we move forward. Many of you have read the abstract, so I will take you through the strengths and weaknesses of the study, which I've analysed using the Pedro scale, and outline the study's significance for our practice here. The authors developed a program called My Care, My Call, or MCMC, which involved trained peer health coaches who have been living with SCI for at least 5 years, coaching community-dwelling adults with chronic SCI. The primary outcome was health self-management, as measured by the Patient Activation Measure, or the PAM, and the secondary outcomes included quality of life, quality of primary care, and service and resource use. First, I would like to take you through the methodology and results. Based on the Pedro scale, this is a fairly strong RCT. Blinding of the assessors was achieved by the project coordinator only administering outcome assessments at baseline and at 6 months, while a research assistant assessed at 2 and 4 months. In this way, the assessor could not see the progression of change throughout the study and be influenced by this when measuring outcomes. 76 out of 84 participants completed the study, satisfying the requirement that measurements be taken for at least 85% of the subjects. 8 participants were lost to follow-up or withdrew, so data was analysed by intention to treat. Importantly, the intervention and control groups were similar at baseline, which further validates the results. The main weakness lies in the fact that the subjects were not blinded. One group received the MCMC resource guide and were called by the coaches for 6 months, while the control group also received the MCMC resource guide and continued with their usual healthcare, but received no new peer or other support services. Because of this, it would appear to be clear to the subjects in each group if they were receiving the intervention or not, and this could potentially create bias when reporting on outcomes. However, due to the nature of the PAM and its good internal consistency reliability, I do not think that this invalidates the results. Another weakness may be that participants were recruited by self-selection. Thus, the study is biased to those who elected to participate, and perhaps those individuals already play a more active role in their healthcare compared with those who chose not to participate. Despite the weaknesses outlined, I believe the study shows good evidence for improving primary and secondary outcomes for people with SCI. There were statistically significant differences between the intervention and control groups for both the primary and several secondary outcomes after 6 months. These are important findings, and I would like to model the benefits of the outcomes on Kim, who is one of our patients here at the clinic. Kim recently came to the clinic due to the development of a stage 1 pressure ulcer. He is considering dropping work, sport, and social activities as he believes this may have caused the ulcer, and this is the last thing we want him to do, as it may further detriment his health and well-being. In terms of the primary outcome, by increasing Kim's level of activation in his own health management, this would give him the motivation and confidence to prevent conditions like pressure ulcers while still engaging in his desired occupations. MCMC uses a client-centered and health empowerment approach, which Kim is more likely to be open to as the expert in his own life, and would provide an opportunity to create new connections and relationships with people with SCI, which are limited due to his recent move from Perth to Sydney. The results of the secondary outcome measures are also important for Kim. The intervention group showed a statistically significant decrease in social and role activity limitations and increase in quality of life, which is exactly what we would like to see in Kim, so that he continues with his activities outside of his studies at university. The RCT also demonstrated increased awareness and use of available services and resources, which is important for Kim as he recently moved to Sydney and therefore is likely not aware of the services available to him. By increasing his access to services, Kim is more likely to be able to self-manage his health and prevent secondary conditions like pressure ulcers, and therefore maintain his participation in activities like work and sport. The authors point out that a larger trial is required for generalisability, cost-effectiveness, and the best way to implement the program. Despite this, I do believe that overall this RCT provides evidence for the positive impact a peer support service can have on health self-management of young people living with SCI. trialling a program of this nature in our clinic could be beneficial for many of our clients.